Hello everybody and welcome to this lecture. We will talk today about guided treatment planning. Of course, we are working on extensive rehabilitation. We will try to tell you how important is the role of the work-up and the mock-up in order to have a predictable prosthetic approach in order to have a successful result at the end of our work. So let me start with the case examination. The case examination starts with the three teams. The patient, that is the most important of the team, the dental team and the lab team. And of course, our effort is that to create a good diagnosis in order to have then the treatment plan that is made in a perfect way, having the chance to follow and to achieve the main goals, and also explaining what kind of modalities you can have it in order to achieve this kind of a result. So it's very important to start with the kind of preview if you can. Of course, today we can use the computer a lot, or you can also use some other way like the mock-up when you have to add volume, for example. Of course, that is a perfect situation in which you can use mock-up that can be direct or indirect. Once you are able to understand your case, once you have catch the case in some way, you can start it to have the chance to explain to our patient what are the possibilities of even of every kind of therapy that you can also propose to him or her. So actually we have to understand the risks, the time, that is very important also to explain it. And of course, you can start always to say to the patient, that's the ideal treatment plan. But at the same time, you have also to consider alternatives that are very, very important for many, many patients, of course. You have to understand the ratio between costs and benefits. And of course, you have to explain also the operative sequence. That is very important because many times the patient doesn't understand, doesn't comprehend that you need to really have different appointments, it cannot be done in once, of course. And of course, as I said before, you can use the mock-up and explaining our patient to do different kind of a choice. For example, it can be like 6 anteriors or the entire arch, for example. But once you start to grind the teeth, then you become a kind of potential killer. Why? Because of course, until you have the mock-up in place, mock-up is a kind of therapy, or a kind of, better to say, choice that you can propose to the patient without touching the teeth. That is the very good aspect of the mock-up. And of course, that is very important because as soon as you start to use the burr and your red maniple or your turbine with the burrs, you start to grind the teeth, you start to create an aggressive treatment anyway. So after decided what to do, after decide to do mock-up, maybe not to cut the teeth at the moment, you can have also the chance to try to explain the patient exactly what you would like to give to him or to her. And at the same time, you have to be very clear that once you have finished your work, you cannot believe that your case is ended 100% because you have to maintain the case over time. And that is one of the most important steps that is not so well maybe reinforced as a concept many times. It's very important to have a great result at delivery, but it's even more important to maintain these kind of results over time after 10, 15, 20 years in service. So the prognosis is really an important step. And once the patient agree with your kind of thought, with your kind of road that you want to follow in your therapy, at this point, they have to sign the informed consent and having the chance to go ahead for the procedural phase. That's an important step either that you have to really follow. So starting to think about it, think about what you have to offer to our patient. The thinking process is very important. Knowing that most of the time, when the patient comes to you, comes for aesthetic reason, because they cannot go ahead anymore with this kind of unacceptable result, aesthetically speaking. But you have to explain them that all the time, aesthetic should be combined with function. It's never alone. Aesthetics is never alone. Function is never alone either. So they have to join together to have the good result at the end. So when you have in front of you a compromised dentition, in one word, you should start to have a good diagnosis and then the treatment plan sequence and exactly explain the patient all the steps on the clinical procedure. That is very, very important to let them understand exactly what you plan for him. So let me do a kind of summary about it. So we have in front of you an extensive rehabilitation case. Where we start, what we do, the starting point. Of course, we never start to grind teeth as starting point. Never, never, never. You have to start with the thinking process, as I said already. It means what? It means that you have to start to analyze all the aesthetic parameters and all the functional parameters, one by one, in order to really have the chance not to forget any kind of detail. Very important. Secondly, we go ahead and we ask our dental technician to do a wax-up. Wax-up is a kind of treatment plan in pectore, as you said in Latin. It means is a kind of solution that gives to you the chance to say that is what you would like to achieve as final result, is what is ideal for you to achieve as final result. So the communication with the technicians for the wax-up is essential, is absolutely fundamental. It means that the technician is never a kind of magician. The technician is a great artist maybe, but at the same time is somebody that needs to receive from our dentist many information, how to change the initial situation of the case that we are treated, and of course how to change it from the beginning to the end. So this wax-up represents the end of your work already. And of course, it would be ideal to show this before doing any kind of grinding procedure on the teeth. If you have to add volume, like today is possible to see in many, many cases on wall dentition, you can add volume. You can do the mock-up at this point. That is a reversible solution. Reversible means that you have not touched any teeth underneath. You just cover with the mock-up the entire structure, tooth structure underneath, and you have created a new kind of solution for the patient. Sometimes it's possible to be done without touching the teeth at all. And that is really a kind of real preview. Also on computer is nice, but this is real, 100%, is what you show to the patient in their mouth. So the mock-up is at this point a very important step to be done, mock-up and then provisional. But when you do provisional, of course, you have started already to grind the teeth. So it's a second stage, which of course you can still show to the patient what you want to do it and what they deserve to have it. But at the same time, with the mock-up is even better because it's a preview before starting to work on patient. So it's still reversible 100%. Again, wax-up, mock-up, and provisional are then at this point ready to show to our eyes what happened in terms of aesthetic and functional integration. And also to show to our patient how it works. And of course, if you're satisfied, the patient will be satisfied either at the same time. But it's not enough. Sometimes you have to put implants and removing the teeth. Sometimes you needed to do ortho, to do other stuff, or to do some the surgical crown lengthening procedure. So at this point, you have to wait maybe some time, like a few weeks sometimes, or a few months another time, to really understand and to wait for the soft tissue healing, soft tissue maturation. At this point, you should achieve this result, to have your work done in a proper way that is perfectly integrated from aesthetic, functional, and biological point of view. That is our goal all the time. And once you did this, then after having waited some time, some weeks, few weeks or few months for the soft tissue maturation, you can copy this kind of solution that you have achieved in the patient in the final result, in the final work. And that's, I believe, that is a very important step. So that is a kind of approach that is, of course, exactly what we have tried to teach in these lectures, the entire course of PROS. And of course, after that, you have to play with all ceramic restoration. All ceramic restorations, of course, is something absolutely nice to play with. We know that we like it to play with these all ceramics. We came from a long time ago, we have used metal ceramic work, and then still using maybe some incredible particular case, specific cases, but normally we use 99% of the time all ceramics. Of course, the word of all ceramic is very important. It will be very attractive for everybody. And today, zirconia in one side, and lithium disilicate on the other side are the ones that really are offered to you in order to achieve the best result aesthetically, but also in terms of survival rate over time. Of course, that is valid also for implants, not just for teeth. Of course, you can use this material for veneers, tabletop, onlays, inlays, buccal-occlusal veneers, crowns, bridges, everything. So in one word, the so-called minimal invasive prosthetic procedure technique, in which you try to preserve and not to be aggressive, and to preserve all the enamel as much as possible you can do it. So all these steps will be again explained step by step in the 10 meetings that we have together. Let me start with extensive rehabilitation. And let me start with a guided treatment plan formulation. Of course, our goal is that to communicate with the dental team, orthodontist, implantologist, what we need to do. And of course, this kind of information should be also given to our patient. Not to say that, of course, it will be very important to communicate, as we already anticipated to you, these steps to our dental technician for analog or digital workshop. And then, of course, we have to consider that there will be a possible integration with other digital workflow systems that are still possible to achieve. So data collection are needed in order to formulate the appropriate treatment plan formulation. That will be the most important step to be remembered. I personally have started already many years ago to use a kind of aesthetic checklist. That's the final version that I published together with my book, Aesthetic Analysis, in 2004. But I've been using this kind of aesthetic checklist already for many years. Why? Because I wouldn't forget any of these parameters. So all the parameters are catched one by one in order to be able to achieve the best result. At the same time, we have also the second book that came out in 2007, 3 years later, a lab chart. In the lab chart, you have all the aesthetic, all the functional, that is all the aesthetic parameters, all the functional parameters. They are combined together in order to achieve the good result, in order to have the chance to optimize the level of our data that we can really transfer to dental technician. So that is very important, but at the same time, that are together with the two books, the volume 1 and the volume 2, that they were then published and translated in 12 different languages, as you could see from these pictures. 204 first volume, 207 second volume. So analog versus digital. Today we go forward, of course. Every day we improve. We know more things about all the digital work. And of course we are more closer now with the digital than before. That is the reason why a couple of years ago, we started to produce this kind of app. It's called Get App, Guided Aesthetic Treatment App, with the iPad, as you could see from here. You can have inside all the data collection in order to formulate, as I said before, all the treatment plan. What the characteristic, what the feature of this kind of app is an easy tool that guides the clinician in the formulation of treatment plan. Actually, you could say that it's very important because you have a communication with the lab, as you said before. We have communication with the patient. We have a communication with the with the other team, with other people of the team, implantologist, orthodontist. And again, with possible integration with the digital workflow system. So very important steps that are to be followed one by one. As you could see from this, we have a red circle on the upper part and a green circle. The red circle is the data collection. All the green one is the data processing. So you can stop in the middle after the red circle and waited for, having the chance to elaborate all the treatment plan that you express on the green circle that you have seen. So data collection starts with a picture. In the picture, as you can see here, we have two levels that guides you all the time. You can see level here, vertical and horizontal, also in this one. And you have also some mask, as you could see, this mask, the red spotted the line. And actually, this way, you can have the chance to really, once you have already set the natural head position, to maintain the same position all the time, and to have the set up the pictures in the proper way. Together with the picture, we also use videos, movies. Why? Because the picture, even though are very important, still they are a static moment of a dynamic action. So that is very good limitation. So if you look at these kind of movies here, you can see the full smile, the S sound, the F sound. All the videos are presented here. So you can have the chance to really see the patient moving the lips, moving the mandible, expressing her smile, etc., etc. So that is much more vital than just giving the picture. That's just some example of what you can do. This example of all the kind of parameter that you can go through, like smile line, labial corridor smile width, interincisal line versus, interincisal line evaluation, the upper, the lower, midline of the face, many others. Now I cannot present you everyone, but just to give you like a sign, you can have the app that already start to guide you 100%. Because all the knowledge that we have as a group, we have achieved, we have put inside the app. And actually it's very interesting, because starting from the first screenshot, when you ask the patient, you are like 20 years old, you are female, or 60 years old, you are man, the final target, the final goal will be different. And the app set up already itself in that kind of goal. Just to give you an example. As you maybe know, incisal edge position is the first step of our prosthetic rehabilitation all the time. And the tooth exposure of the central incisors are exactly the starting point of the incisal edge curvature. So let me explain to you. Once you say Paolo Rossi, and is actually a man, is 60 years old, he can show at rest normally as average 0.5. At the same time, a woman at 20 years old can maybe show 3.5. So different in that kind of value. And starting from that, you can understand that immediately the app gives to you the chance to set up the app exactly with this goal, to achieve this result, that is individual result, specific one, for each one of your patient, not for everybody. It's not generic one, it's really customized. And then you have other kind of instruction. I cannot go through this completely 100%, but just to give you an idea, like give you an example. This was the initial situation. Length was 7 mm.9, 8 millimeter. The exposure at rest was -1, so you could not see the teeth at all. And the incisal edge was 1 millimeter down to the upper lip, and the width was 8.7. So the ratio was 109%. It means the width was 109% and the length. But that normally the opposite. It means the width is 80% of the length. So the app knows that and automatically gives to you this chance to give to you the final numbers. And you can see that is exactly or not, because it's red but it is green on the right side instead of red. So you can understand that you are really into position to really replicate this kind of work. So because that is perfectly. Now we have 1.8 of a tooth exposure at rest and 10.7 in terms of incisal length of the upper incisor. So in this way you can have the chance to move the teeth more out, more in, to lengthen, to shorten, and to be guided again by the app itself that guides you 100%. So you can find at the end the kind of final result, the final the final data. Of course, you can still work on it. It means you can still modify as you like it. And as I said before, it's not just an aesthetic parameter that's counted, but also the functional one. Let me show you. That is 9.1 step. And is a kind of rendering. Why is nice? Because we have obtained already all green number. Great. But if you want to still customize, look, press there and then go to the upper. Look, now lengthening. And now all the value around it they are changing. Also the length changing, shortening, and all the value here are changing automatically. But you can have a kind of preview or real view of what could happen. As you can see, go more out, more in. You can change it, all the numbers change. In this case, it didn't change at all because it was perfect. Then you have the red button there, and you have a kind of a screenshot. In every screenshot, you have a kind of explanation, like an e-book, an explanation of all the steps. It's very, very useful because if you're not so well prepared to this argument, to this topic, you can have it. That is a question mark, how to work with your finger in English. That's in English language. So, at this point, also with the video, you have to increase the video, for example, you can preview at this level here, that you can have the increase of the length of the lower. Look, now it's lengthening, and again, can arrive up to the lingual part of the upper teeth, or maybe better to stop because you are still green, but then become red. So you can thicken it. Look, you can have the chance to have this kind of situation here. Palatal thickening. And now, with the palatal thickening, now you have the contact. So you can decide, looking at this kind of rendering, how much increase the lower, how much to increase the upper. In terms of length of the lower and lingual concavity, palatal concavity of the upper anteriors. And that's what you can achieve it. And again, the red button showing all these kind of topics. Good. So again, if you're interested to see it, go to Apple Store. Fradiani or Fradiani Education Get Up. Better to say Fradiani, you can find it. Now you push a red button. With the PDF, you send, maybe for the first time in your life, you can have the chance to give to a dental technician or to other dentists, to other colleagues, all the data that you have collected together. So it's great. At this point, you can go ahead with analog way or fully digital. Because, of course, you have all the value that you have achieved in the middle here, how much to increase it, to put more out, more in. So you can have the WhatsApp digitally done, or in the different way. You can have the Facebook taken in the regular way, as you could see here, or having the chance to do digitally again. So, regarding the Facebook, in the traditional way, I would like to stress one point, because many times I could see some miscommunication. And I would like to say that normal way should be what you see here. This is an ideal situation. It means that you have an horizontal incisal plane that is parallel to the horizon. That's the horizontal incisal plane here, okay? Is parallel to the horizon 100%. At the same time, eyes of iliac line, they are parallel to the horizon too. And at this point, commissural line also parallel to the horizon. So that is an ideal situation. And of course, in this way, you take the face bow. The arms of the face bow are completely horizontal, in horizontal plane. So everything goes well. Because once you put your face bow into this part that represents the condyles of the articulator, you have the chance to see that the incisal plane is absolutely horizontal, parallel to the horizon. That is starting in this way, and arrive in this way. Identical, of course. Remember, the two condyles into the articulator, these two, 1 and 2, they can maybe have a great regulation in terms of immediate Bennett, progressive Bennett, and else, also something else, like the condylar path inclination, for example. But I don't know any articulator in the market that has the chance to go up and down, up and down. They're stable in this position. So the Facebook is obliged to go and to refer to this condyle. The condyle cannot move up and down. Remember that. Why remember that? Because once you have a situation like this, in which one condyle is in higher position than the other one, or even one ear is in the higher position than the other one, this could be higher than this, or this meatus higher than this, but still you have horizontal occlusal and incisal plane like this. Once you have the arms of the Facebook that for this reason, for misalignment of the condyle, or some mistake on taking the Facebook on the ear olives, at this point, once you have a piece that is, once the arms are collected together with a fork, is one piece altogether. Now you transfer all this into the articulator. And once you transfer all this into the articulator, you see that the incisal plane that was absolutely horizontal now is inclined on one side. Why? Because again, it was this inclination before on the head of this guy. At the same time, as I said, the two condyles here cannot put more up or more down, like is here with this Facebook. So the Facebook is forced to go to this reference point mechanically, so he cannot move it. And automatically, being one piece, arms and fork being one piece together, they are connected together. Of course, this kind of conjunction between the two pieces that are fixed allow you not to have the perfect incisal edge position, but it is slanted automatically. We was slanted here, it was perfect incisal plane. When you have here the situation that you should find into the articulator, automatically the incisal plane becomes slanted, become inclined. So at this point, you see that once you do that, the technician tries to help you maybe in achieving the best result, having this model that is inclined. The technician, if normally he talks to you, he explains to you that he can find some strange things, maybe you can talk together and you can solve the problem. But if you have the technician that doesn't give to you any kind of chance to talk together, at this point, he try maybe to improve the situation for you and try to elongate the teeth on the right side, as we did. You see here, now you have longer here than here, but is now horizontal. But is really the horizontal situation that you have in the mouth? Probably not. Why? Because when you go back to the mouth of the patient, this situation that seemed to be in the articulator perfectly parallel to the horizon become inclining one side automatically. And if the technician lines up the incisal edge of any restoration parallel to the bench top, the incisal plane would be angled. That is not something that is said by Fradiani, but by Peter Dozo, that is the last neonatologist that was just passed away unfortunately, just a few months ago. So the slanted incisal plane, remember, is one of the most aesthetic, unacceptable mistake. And that's for sure. Why it happens, as I said? I said because maybe one condyle is higher than the other one. But the main reason why is not that. Because we don't see the condyle if you don't do any kind of pantography or some other kind of instrumentation like that. But it's because into the meatus, acoustic meatus, the two arms can be really dislodged in a proper way, in an improper way, I could say. It's a giant movement that can be possible. Take a look. Now we are with the two olives over the Facebook inside the meatus. Take a look with my hands. I can move inside, still being inside the meatus. So it can be really wrong. So your duty is that to put yourself in front of the patient, maybe using also a level like this. You see that is a level there. And check it with the horizon if you are parallel to the horizon. With what? With the two arms, right and left arms of the Facebook. Remember, these arms of the Facebook, they are connected by this to the fork. So it's one piece. And that's the main reason. If you start to see that this one is slanted, is taken slanted, and the fixed is slanted. Then you go to the articulator, you have some angulation that maybe is not present in the real life, but is present only into the articulator. So this is again what you should do. Even though one meatus is higher than this one, anyway, the face bow and the arms of the face bow is taken parallel to the horizon. In every case, even though you have to move a little bit out, it's not a problem, as Peter Dozo said. At this point, you have a correct registration, and you have, again, this that is parallel to the horizon, because the arms are parallel to the horizon. So in one word, if you start with that, take a look at the patient, in front of the patient, go to the front of the patient and check it. If you see the arms that are inclined, so you have to move it like this until you are parallel to the horizon. At this point, you are able to replicate into the articulator the position of the incisal edge that was already, since the beginning, parallel to the horizon. That is what you want to achieve. So, the final recommendation is align the face bow to the horizon. A slightly missile condylar axis, if you have it, will have insignificant effect on the arch of closure. And again, that was Peter Dawson in 89, long time ago, more than 30 years ago. So let me go ahead now with the treatment plan with the works-up and the mock-up. First of all, let me introduce to you Max. He's from Florence. He's requiring to have a kind of fixation of his teeth. But once we checked him to talk, he said, fixed teeth, maybe he needed to denture. He had no teeth underneath. No, the teeth are there. You can see it. He's a heavy braxer, destroy all the teeth, as you could see here. And we need to restore him. Of course, yes. But we start, as always, with the position of the incisal edge. That is the starting point of every kind of prosthetic work, or removable and on fixed prosthodontics. So where you could find teeth there, you can see the tongue, you can see the lips, but not teeth. Now you can see, in bigger smile, you can see that you have the incisal edge is 5 millimeters underneath the upper lip, also the lower. So they are not visible at all, 100%. The length of the upper are 5 millimeters approximately. So that's the reason why, you see, 5 millimeters underneath. Crazy. So you need to show some part of the teeth at rest at the end of our work. You should increase at least 5 millimeters of length. At the same time, you say that this 5 millimeter length is already the length of the central incisor before the treatment. And the normal incisor length on the healthy one, on the normal one, is more than 10 millimeters, 10, 10.5, 11. So we are really missing more than half of the teeth, original teeth, on the upper and the lower. So horizontal braxer, you see, you have shortened the teeth, you have big diastemas between the two central incisors on the lower, between lateral and cuspids on the upper. And we also would like to check what is the mandibular position. We have another lecture that we talk about all this stuff, functional stuff. But in the meanwhile, we try to remember that is the CR position that are needed to be achieved once you have to rehabilitate the case like this, because we have lost all the occlusal surface. We need to position the mandible in the right position, that is in the CR position. So before starting, in order to study the case, we need to have some functional information to be sent to our dental technician. So we take the face bow, as you could see here, the two-stone model of the initial case, plus two other kind of bite records. One is the CR record, and one other one is the protrusive record. The CR record is to mount into the articulator these two stone models on this new position. And the protrusive record is the record that you take it between the posterior teeth when you go forward with the upper teeth, with the lower teeth, to have the edge-to-edge position. You can create some space on the back. It does allow you to regulate the condylar path inclination to the real value and not giving to the technician maybe an average value of 20 degrees. But we discussed that in another lesson, another lecture. So dentists, stop models, face bow taking, CR record, protrusive record, and of course, we have some other functional informations, and with the get up that gives to you all the information about how to change the situation, as you have seen already. So, would you like to increase the video in a case like this? Do you believe that you have lost the video? It will be a long story, and again, this is a kind of lecture that will be in another lesson, another part of the course. But actually, what you could say in this case is that probably he lost the vertical dimension, but it's not said that is 100% true all the time. Why? Because many times you have a compensatory phenomena by the new opposition of the bone from the cementon of the roots. So, at the same time that you are grinding the teeth together, grinding and shortening the upper lower teeth, at the same time you could have a kind of compensation phenomena by an extrusion of the teeth. So, for the new opposition of the bone underneath. I would like to show you an example of that. In the meantime, some articles. If the eruption occurs at the same rate as tooth rate, the video could remain unchanged. But if not, the video may decrease over time. So, but it's difficult to say. Look at this. That's very useful. That's the normal situation here. The length of the teeth are normal. And A is the bone height. Now here, the teeth are much, much shorter. A is shorter than before. It means that you have lost, for sure, some height between the teeth, but you have gained some more bone underneath the roots of the upper and lower teeth. So it's a kind of compensation phenomena. It's never 100% probably, but it's very complicated to test it and to know exactly. But that is a kind of mechanism that can happen. Now, when you increase the video, you have to ask yourself, what about the possibility to change or not? So that are some concerns about it. What happens when you increase it? How to decide the amount of the increase? And how to test the increase? All the 4 questions are absolutely understandable. Because you need, first of all, to know if it's possible to change what the literature said to you. Literature have changed a lot their kind of thought over years, and now mostly, I could say a big majority of articles show that it's possible to change it. This an article is a kind of systematic review that was made by Abduo in 2012, and is concluded that the video that is increased up to 5 millimeters anteriorly, just in case you need it to increase it for clinical reason, could be considered a safe and predictable procedure without consequences. If you have some signs and symptoms, they are self-limiting with a tendency to resolve within a couple of weeks. Very interesting. Very interesting. So, laboratory communication is very important. You should say, normally, when you ask dental technician what you receive from dentist, and the normal way is what is written here. Maybe you don't know Italian, but I can try to explain you. Alzare un po' la dimensione verticale. What that means? In English, increase a little bit the vertical dimension. What do you mean little bit? It's a very generic term. For me, it could be 0.5. For you, can be 1. Can be 1.5. And more than that, nobody is saying where, upper or lower. That's very important too. Why? Because many times, like me, for example, I now showing only the lower. Would you like to do half and half, upper, lower? If you create 3 millimeter my video, I wouldn't do it, because the lower will be even more visible. So that is a clinical test, cannot be let the technician do it itself. You have to transfer this information to the dental technician. Because you look at the patient in front of you, you have the patient in front of you. So you can decide it. Not technician for you into the articulator. It's not valid. Not good at all. Please, forget it. So you have to really give the information to dental technician. And not say un po', un peu, a little bit, shoot, but being more precise. Then, dopo aver la serratura, falli belli. Do a good job. Geez, please. Very generic information. So we have increased lower and upper. So we have to specify to the dental technician the suggested video increase. And looking the patient, you could see this was in the book, the checklist of the book, the lab chart. Vertical dimension, unchanged in this case, but you could also have increased it. Maxillary, mandibular, decreased maxillary and mandibular. So it's not something new, it's completely old stuff, but still valid. So upper, lower. So specified to the technician, also this app is the same. In the app, like in the lab chart, we have the same information at the same time. So in one word, we should send to dental technician all the information that they needed to really do a good job. And to do it, of course, we need to have more information as much as possible. First of all, determine length of the upper teeth, upper, lower. Determine the incisal position of the upper and the lower arch. That's the starting point, as I said already, of every prosthetic treatment in fixed pros and in removable or in denture. Then, third point, orientation of the occlusal point, of the occlusal plane, sorry. So incisal plane and also the posterior area, to cuspid to molar, to have the chance to see that the occlusal plane is well oriented. Then, the video determination, how much you want to increase it anyway, even though you believe that maybe not lost completely, but you need a space, so it's a good reason to increase the video, as we will discuss a lot on the lesson, on the lecture on this topic. And then, occlusal posterior stability in centric relation position with a very marked contact on occlusal stamp, occlusal cusps, and actually with the chance to have light contact on anterior, as you could see here, to have an anterior guidance. So, well distributed, equal intensity, a synchronized, marked contact on posteriors, and light contact on anteriors, ready to be able to guide the anterior guidance and to form the anterior guidance with the incisal guidance and lateral guidance with the two cuspids, if you want to achieve the cuspid guidance, or cuspid and bicuspid if you want to achieve a group function. Normally that's the two occlusions that we use in fixed pros. So all these are information that the dental technician need to receive in order really to catch the case the proper way. So there are indication, recommendation for dental technician. Now, we have increased the video. Of course, you have to measure before and after you position the CR record between the two models. You increase on your pin the 3 millimeters, the three steps that you see in the pin that represent the 3 millimeters that you have increased with the wax up. And then if you don't want to increase the video in this case, you want to keep the video as it is, for example, you remove the wax, that the bite record, of course, that allow you to put these two models in CR, and then you start in the lab, dental technician is saying, in the lab start to do the occlusal adjustment until you arrive up to the end. At the same time, use also the protrusive record, as I said before. You ask the patient to go edge to edge, and then you have some space that is forming on the back that will be higher or lower depending on this. Now you have around 40 degrees. If you have 20 degrees or 25 degrees, it will be more flat. If you have 40 or 50, it will be more steepness, like here. Okay? You have the space that is formed thanks to this. Of course, the incisal guidance, the anterior guidance, plus the posterior guidance, that is that of the condyle path inclination, that is just shown here, the condyle path inclination. You see the condyle going down to this kind of path of inclination. And actually, we'll be opening the space on the posteriors, achieving the goal not to have any kind of interferences during excursive movement of the mandible. So that is our goal, in order to avoid any kind of posterior contacts during excursive movements of the anterior guidance. So the condylar guidance, that is in this case steeper, allow you to achieve easily this kind of result in this case. This is a protrusive bite record. So all this allow the technician to achieve this result. This is the workshop. Workshop is made, is completely in addition in this case. You have seen how much you have lost to structure before. So that was before, left side and right side. And now we can use this as mock-up because we have the chance to avoid any kind of grinding procedure on teeth, because the mock-up is completely over the original models. You have closed, Giancarlo closed in the proper way the holes at the space between the teeth, as you can see, also the lower arch between the two centrals. Great anatomy that was done. So remember, the workshop is the representation of your treatment plan. And of course, you put inside all the aesthetic and functional parameters, having analyzed all the aesthetic and functional parameters in the proper way. And then become a prototype for mock-up as first, and then for provisional when you have to grind the teeth to take an impression. You could see in this case we have increased the video up to 6 mm. Normally we increase up to 3.5, that's average. But in this case was really lost a lot. So to achieve the best result, we need to increase 6 mm. And at this point you can do the mock-up. Let me show you this movie. We have taken the registration about the initial increase, the initial height between the two arches, between the two central incisors, was 12 mm approximately. Then we tried this kind of silicone matrix, and then we are able to put inside this bisacrylic that is positioned in the mouth. Of course, the anatomy of this silicone mask is that of the workshop. So we are trying to stamp, to print this mock-up in place. And the workshop values was now optimized in the mouth of the patient. That is perfect. Now we do the lower arch. Again, we printed this bisacrylic in place. And again, remember that we have followed the anatomy, the new anatomy that we have achieved to the workshop. Workshop that was derived from our kind of aesthetic and functional parameters follow-up. Look, now it's perfect. Now you can change some little things. Maybe this is not allowed to use it, but it's perfect to divide perfectly the teeth between them. Look, so I use a little bit. I did just very little modification before let him looking himself. And you will see now the eyes of the patient that you can feel it, some doubts. What is doing this guy? Talking about me. But I know the result was perfect, but he didn't see it. So now you see that he's closing the mouth. I will just touch some little things. We are able to then finalize the case. And look then, after he saw himself on the mirror, changed completely the attitude of the patient. And that is nice to see the patient now happy. Now in talk, you can show the teeth. Finally, the final work was absolutely good. He was very happy about that. You have increased the video. Remember, we have created now space between the posterior teeth, excluding the posterior teeth. Of course, you have control the functional optimization of the occlusion, upper, lower. The mock-up can stay in place for a couple of weeks, depending on the patient needs, depending on many things. But anyway, that is the result that they have achieved. Have increased the video. We didn't cover, as you could see, the recession on 21 and 22. As you could see, we have some recession. We will finalize our work on the CEJ, so making these two margins completely supragingival. Why? Because the patient, when he laugh, doesn't show at all these areas. So it's not important aesthetically. It doesn't have any risk to have problems up to now. You can do also this work later on after we finalize the work, if you finalize your margin on the CJ as we did. That is an option on the treatment plan. So again, increase the VDO. In the past, we had problems on accepting this kind of solution, but now all the authors say the same thing. You can have at most transient patient discomfort, no muscle pain, no joint pain. So many authors agree on that. We have also other articles that I will show you in the next lectures. We check the occlusion properly, stability of posterior teeth in occlusion on the functional cusps, centric cusps, and then light contact on anteriors, all that in red spots on the left side. And then all the other lateral and anterior movements of the mandible that gives to you the idea how it works, the anterior guidance, incisal guidance anteriorly, and canine guidance laterally, right and left. Now we can start to cut back and to go ahead for the final work. Once you have the chance to cut how much you believe that you need to have for you to leave for your ceramic material. You need 0.5 millimeter, 1 millimeter, 1.5, 2 millimeter, as you like it. So you cut back the same amount starting from the mock-up. Of course, having increased the VDO of 6 millimeter, you can find a lot of space available underneath. So you probably don't have to be aggressive at all on the teeth underneath, because they are already over-prepared by the nature, by the wear. And that is the smile of the patient that changed completely their life in terms of having the pleasure to smile finally. That was not possible before. He was saying to me that he was not laughing anymore because the teeth were not visible and because he had a reverse smile. And now she can really enjoy the new style of the teeth. We are still in the mock-up. We will have another lecture to show exactly step-by-step this case from the beginning to the end. But now, for what we have seen, what you have said, I believe that is enough to explain that is a kind of a guided aesthetic treatment, guided treatment plan, having analyzed step-by-step all the aesthetic analysis, the functional analysis, join together the two parts, and having the chance to give all the information to dental technician in order to really optimize the final work, giving instruction, recommendation that are coming from what? From analysis of the aesthetic and the function. That is today also much easily achieved by the use of GetUp, the guided aesthetic treatment app that is really very helpful on this side. So I would like to thank you to stay with me for this lecture. I will be back to you for another lecture. Bye.